investigative report came out on LinkedIn saying that he had a story, and this was in the throes of his addiction. I didn't respond because the message was a little bit chaotic, but then he went to rehab shortly after, and now is a very committed advocate for trying to raise awareness about what is happening here. So I want to welcome these guys. So the first question for both of you is, can you just tell us a little bit about the addictions issues that you struggled with and how Safer Supply made them worse?
Should I start?
Yeah.
Okay. Well, in the early 2020s, and it kind of started a little bit before, I was messing around with Percocets, and then I graduated to Oxys during the pandemic. And then eventually, I was working, I basically burned through a lot of my savings, and I was running out of money. And I was working with a guy who had actually been fired for smoking fentanyl and crack on the job, and rehired because in construction at the time, which was one of the only jobs you could work, without the whole, distancing guidelines getting in the way of it, it was very hard to get, installers. There were people who could install things right away with they already had experience. And so they brought him back on when I started working there. And I very quickly realized when I was put on a crew with him that, he was addicted to drugs. And, I run out of money, and I said, man, I can't afford this anymore. And he's like, dude, come to the new building I've been put in. Because he initially was living in shelters and place like that. And he got let into 122 Baseline, which is a place, in London. And it's a supportive housing building, rent geared to income. And basically, he said, every floor of my building, there is at least one unit, but definitely more, that have access to these things, and a lot of them. I ended up going there, and I was amazed. At first, I didn't believe it, but the prices were so cheap, I couldn't ignore it. And eventually, it ended up graduating to the point where, even the dilaudid were not strong enough. So I started mixing them with some of the extended release pills, like the Cadians and the Eslons that they were getting, and people were getting so many. And dealers weren't wanting to trade or buy it off of them, or not enough people were going there to buy the extended release pills. That I was able to get those for $1 each, and those were 100 milligram XR Cadians and Eslons. So I started mixing up to 10 to 20 of those at a time, with about 10 to 20 dilaudid 8 milligrams at a time, to the point where my withdrawals would literally start at lunch because I was taking so much. And eventually reached a point where I had to go to rehab. Should I just pass it on?
Yeah, and that's Will.
Thank you. Yeah, so my name's Will Hawes. I'm actually a nurse practitioner, currently in the non-practicing class right now, so I can still call myself a nurse practitioner, but not working clinically. So, like you were saying, if I go back to how my addiction started, before the Safe Supply program, it's a similar story with getting prescribed opiates, responsibly through doctors, okay? Do I blame the Safe Supply program on, the bad choices that I made in my life and how I got to this point? No, in certain aspects, but did the Safe Supply program escalate my addiction to a point where it nearly killed me? Yes, where it nearly ruined my whole family, affecting my children's mental health at this point, everything, my divorce, everything. So, when we're talking dilaudid 8 milligrams 20 years ago, $20 on the street, they're $2 on the street right now, right? Or whatever they are. I've been sober for 2 years, so I did go to rehab. I went to Bellwood in Toronto. When I look back now, I'm kind of thinking, where do I go kind of with my life? Clinically, I don't want to go. I used to work in forensic mental health, and my addiction sort of spiraled out of control during COVID. A lot of stress. That was before the Safe Supply program. Once I sort of heard about the Safe Supply program, that's when things became completely out of control. I had access to, you know, the amount of drug, like the milligrams that I wouldn't afford. In the beginning, I think I was taking a quarter of an 8 milligram P8 orally. By the time I went into rehab, I was injecting 240 milligrams of Dilaudid a day. So it was very dangerous. I was very sick. And I would never have had access to that, right? So.
And how did you buy it, and where did you find it?
Well, I bought it right outside the pharmacy. When the patients would come out of the pharmacy, they would run to your car, and it was a feeding frenzy. It was exactly what everybody's saying, you know? Like I'm not here to judge people or to say who's right or who's wrong, but, you know, there's incentive for money there, there's a lot of money, and I've heard earlier in the evening, somebody was saying, well, I think you said 20 to 30 a day. In the beginning, some people were getting 40 to 45 Dilaudid 8 milligram a day.
And just for context, 2 or 3 of these is enough to cause an overdose in someone who is not a regular opioid user, like a teenager.
Yes. So 1 Percocet is equivalent to 1 milligram approximately of hydromorphone or Dilaudid. So that would be like the height of my addiction, taking 240 Percocet a day. So that's a very dangerous amount, right? But opioid tolerance, there's no ceiling effect to it, right? We all know what it's like for withdrawal. We've been through hell, we tried it, and you know, so that's where I'm at right now, kind of in a point in my life where my family is sort of, they don't understand the politics, they don't understand the addiction part of it from how the safe supply part of it fits in. So that's kind of where I'm at. What can I do? Where can I kind of put the pieces in and kind of help others?
And so, I mean, we've spoken before, and I know that the pharmacy that was prescribed the dispensing all of safer supply, I'm not going to name it because we don't want to get sued.
Okay.
But so you would go to the alleyways behind the pharmacy or around it.
Exactly, yeah.
And so you also mentioned to me previously that you would see drug dealers purchase, just vacuum up scripts. Can you tell us more about that?
Yeah, so, I mean, I remember in the early days, once sort of the supply and demand sort of happened, price went down, supply went up, fentanyl dealers came in, so there was sort of a combination of drug dealers were coming in and they were making deals ahead of time with people who had scripts. So every day they knew they'd come in, they were getting 20, 30, whatever they were getting dispensed. They would give those directly to a drug dealer and get their fentanyl or whatever, and that would be that. Or they could sell it to somebody else who was there, you know, desperately waiting for something that they wanted, which was me at that time and many other people.
Okay, so many safe supply advocates, they say that diversion is actually not a bad thing. And they say that diversion is actually just an act of compassionate sharing and mutual aid, and that safe supply recipients only give out their diverted safe supply to other drug users who are struggling with withdrawal, and that it's all very altruistic. So, starting with Callum first, would you agree with this assessment?
Definitely not. There's a lot of like profit incentive. Plus, they're also just trying to survive their addiction too. So like they're going to do whatever they can to buy however many points of fentanyl that they're going to buy that day, or you know, whatever amount it is. So you know, I was kind of almost a godsend to some of the people that I met. Like they were so happy to deal with me and get me to buy pills from them. They were willing to give me deals. You know, if I bought in bulk, and you know, it was pretty cool. Like just, or well, not cool, but like for me when I was addicted, I was like, whoa, like they're actually saving pills for me. You know, like they're telling me, oh, I got 5 bottles in the cabinet for you when you're ready for them, because they knew I was a consistent buyer and they wouldn't have to trade for product and get a worse deal than me buying it, even if it's for $3 to $5 a pill, you know, or $1 for the extended release pills.
And Will, what do you think?
Yeah, I think I completely agree with that. I had done the same thing where I had met people and worked out deals with them and said, you know, okay, I'll buy from you every day. And for a while you'd meet somebody, and there were actually, for a while I was buying, I believe it was a very large amount of, I can't remember how many D8s it was, but it was something like 30 Canadian 100s as well, with a week's supply, like a week's script. Some patients in the beginning of the program did get a weekly supply of D8. So we're talking 240 dispensed once a week with 100 Canadians, okay? So if you set up a contact, and when you're in active addiction, I know exactly what you're saying, it's like, holy cow, now I've really got it going. I've got things going.
Yep.
And Adam, in your documentary, where the young women were saying, you know, once you never think to yourself, well, I'm not going to get addicted. It's not going to be me, right? It's not going to be that person. I can, but once you cross that path, it just sort of, there's a gray area, and then you don't know who you are anymore. And then things just kind of go in a way that your life never thought would occur.
Now, I just want to get a sense of how much safer supply was trafficked here between you two. Let's quantify how many pills spilled into the community that you are aware of. Throughout the course of your addiction, how many D8s do you think you bought? And other pills? And how much money do you think you spent?
Oh, thousands. You know, like at least thousands, at least a couple. You know, and like hundreds and hundreds of pills. You know, like there would be times where I'd buy, one time I got a deal for 80 D8s for $100. You know, and I bought it all at once. Or like I'd buy, at one point I was buying 50 Cadians or 50 Eslons with 30 D8s or 40 D8s. And this is over like just over 1 week or even a couple days at one point. So, you know, at a certain point by, you know, halfway through the week, I was going through, you know, 25 Eslons, Cadians, more probably, and at least like, you know, 50 D8s, you know, 60 D8s at one point. It was a lot. I was taking so much that at that point, even at the extremely cheap prices, I couldn't even, you know, keep up, you know, and it's crazy how much people get. I met people who were getting, you know, 20 Eslon a day, 20 Cadian a day, plus 30 D8s a day, all given to them on Monday, beginning of the week, for the whole week, which is hundreds of pills. So you can just come there and say, give it to me, give all of it to me.
That's insane.
Yep.
Yeah.
Will?
And I would say, like over the course of from before 2021, it was Father's Day that I actually sent in rehab June 16th, 2023, before I went to Bellwood in Toronto. I would say $120 to $130 a day I spent for 2 years on Dilaudid. If I could get around convincing people I wasn't a cop, that was my biggest thing, but I don't know why.
I have a problem too.
But sort of, you know, the humor of it, but a lot of money. And, you know, for me, I was, you know, I had just started, I finished school, I had a good career, everything was going well for me. I'd been married for 16 years. And you know, that when you start to, when you can't hide that money, right? And then when you do start hiding it, the guilt and shame goes up. Once the addiction becomes a full-on addiction, the withdrawal, everything, your life becomes a mixture of just like a melting pot of guilt and shame. And when, you know, I would drive there some mornings to this pharmacy and, you know, think to myself, am I going to drive home and just like tell my wife what's going on, or am I going to just get myself unsick and go to, you know, and then it was just a daily struggle from there.
So last question before we go to the Q&A section. There's a conversation about the role of organized crime in trafficking these drugs. And I'm wondering if you observed that over the course of your addiction, and if you can describe what that system looked like. I feel like Cal, from our conversations, you'd be very well suited to speak about this one.
Yeah, so one thing I made a point of doing when I got involved with, higher level drug dealers, because I did, at least with one of them who was higher level, I never wanted to know his name, and so I would be safe, just in case if he thinks I said anything about him. But he would tell me all the time, especially when I was buying D8s, he'd say, if you can save some up for me, I'll get them from you. And then, I'll go somewhere like North Bay or Thunder Bay, and sell them for $30 each, or do you want to come in with me on something like that, and we could both make loads of money. We'll stay in a motel for a week, sell all of them, and make a couple grand, come back, and there's a lot of that going on, for sure.
Just for clarification for the audience, so the price of dillies, it depends on where you buy them. So if you buy it directly from a safe supply patient, you can get it for like $1 or $2 a pill. Then you can sell, they'll sell it to a drug dealer who'll sell it in the area for maybe $5, $6, $7. But if you go up to Northern Ontario where safe supply is not that available, you can sell these pills for $20, right? So just imagine the amount of money some higher level criminals can make if they purchase thousands of pills in London, Ontario, and then drive that up to Thunder Bay and sell it there. And we have someone here who directly engaged with these kinds of drug dealers.
Mm-hmm. Oh yeah. They it was interesting talking to them about it too, because I would ask them hey, I remember back when I first started doing opioids, talking about D8s, it was very expensive, $20 a pill, and you would hear from people, oh, if you want to get them for $1 each, you got to buy them in the thousands, and they come from Montreal or somewhere like that. These are just things that I heard, right? But later on, it was crazy that even I could get in on that. I didn't want to, but it was something that you wouldn't hear of it. People buying thousands of pills. It would be something that somebody you'd never have met did it, because they're so high up that they have access to those contacts, right? But now anybody can do it.
And another context piece, so in 2019, before safe supply became widely available, the London police seized about 700, 800 allotted pills. By 2023, that number went up to 30,000. So an over 3,000% increase. In Waterloo, we saw a 1,000% increase. In Niagara region, we saw about 1,500%. Other cities have not shared the police data with me, but we can tell that there's something wrong here. Will, organized crime, what can you tell us?
I can't tell you any of the current jobs I'm in right now, but I'm just kidding. That side of it is not really, when it kind of came first, full circle for me when I was in the beginning of my opiate addiction. I was buying some Percocet off the street at higher prices, which wasn't cutting it for me with the withdrawal. I learned about the pharmacy where you could go at 8 o'clock in the morning and just get whatever you wanted, and that was the cheapest place to go. As the day goes on, price increases a bit because there's less supply. In the height of my addiction, was I using some other drugs? Yes. Was I buying them from other dealers who were taking advantage of the safe supply program, using their profits from cocaine or fentanyl to buy surplus D8s and resell them at a higher price? Definitely. But yes, that's my experience with it. Yeah. So definitely there is a organized crime profit issue there for sure. Yeah.
So let's open the floor to questions. Who has something to ask?
So I grew up in London, and my question is, and in my heart, when I go back to visit my family, in London, I can't believe the community that London has become, the community that I grew up in. So my question is there something specific about London in relation to safer supply that might be different from other communities cities who are suffering from the policies around safer supply? Is it worse in London? And 'cause it seems that way to me, and I'm wondering if I feel that way just because I grew up there.
I'll just briefly point on that. I think from my perspective, my sort of knowledge on that is a combination of inter-community health center, the government funding, London being, approximately 400,000 people. A pilot program that had never had that many opioids. London's a very conservative town, so I think it could have been any town, really. I don't think there's anything special about London other than the amount of diverted drugs on the street for the population size, the population density, and also this area like the Adelaide, Dundas, where there's a lot of crime and a lot of drug use. London is very condensed that way. There's a lot of wealthy houses around that area, a lot of high schools in that area. So maybe a good area for treating highly addicted people, because I don't think the Safe Supply program had any bad intentions, but London maybe was just it wasn't the right spot, didn't have the resources, and we talked about the research and all that kind of stuff, which was qualitative, not quantitative. So,
Well, just to chime in, so London is where the Safe Supply program was initially piloted in 2016, and that's where they started all of it. It's the epicenter of safe supply prescribing in Canada.
Yeah.
That's not in BC, that's in London. And your intuition that it's worse in London than other cities is correct.
Yeah.
In 2023, they seized about 30,000 pills, a lot of pills in London. In Waterloo, for example, that was about 5,000 pills, which
So
was...
is it a Southwestern Ontario thing?
Yeah, it's specific to London.
It's specific to London?
Actually, I have something interesting. One time I was talking to, a higher level dealer who would go all across Southwestern Ontario to sell different drugs, but his main supplies were here for specific things like cocaine and stuff. And I asked him why is London the way it is? Because I live there and I've noticed even when I was in high school, before I was doing opioids, you could get Xanax, you could get MDMA, you could get cocaine, you could get you could even get pills at a certain point. And I said is it because of our location? Because we are very close to Toronto, but also close to Michigan as well. And he kind of he nodded at me and he said, it's kind of like that. Plus you're also close to all the other small towns in Ontario in the southern half of it. Plus you're close to Barrie, and all these other places that are close to Toronto as well. So I think it's just a location issue mixed in with everything we've just talked about as well, because people who sell coke in London, at some point or another, it probably either came from the States or from Toronto. There's a lot of high level people, from what I understood from speaking to people in that world, that there was a lot of high level people in Toronto. There was one guy in particular I knew that on Fridays when he had to settle up with them, he would be in a rush to get to Toronto because they'd already be asking, where are you? You owe us, from Monday when he had his consignment where he picked it up and he owed them for the coke that he got.
Okay, next question. Go with Matt.
Maybe an ignorant framing question, but does this issue intersect with, or how much does this intersect with homelessness encampments? Because I feel like a lot of this is sort of hidden to average people, but what is not hidden is what we see on the streets in the form of homelessness. And I wonder, in your experiences, maybe out of your research, what is the intersection, if any, between this issue and the perceived growth in homelessness and homeless encampments in our cities?
You guys want to take it?
I'll start and then I'll pass it off to you. But yeah, I think it does have a direct correlation, because a lot of the people I bought from were homeless at one point and then were put into government housing or supportive housing, and were either in between living on the street or living in the building. And yeah, a lot of it was, a lot of the reason why they got into the main building I went to, but other buildings, was because they've been homeless, and that was also another reason that kind of helped them getting, more safe supply pills. Because, homelessness mixed with addiction, it's a terrible thing to deal with. And, you could see how, people who run safe supply clinics would be more inclined to, kind of meet their needs more often. And, they're also on more benefits too. So it's more advantageous. They can afford to, get the pills, because they're covered. And, for me, it was like an epicenter going to some of these supportive housing buildings of where to get pills. It was like the parking lot of the safe supply clinic. It was like, the center of where you get it. And, and it was similar where if you don't come on Monday or Tuesday, the price has gone up because dealers have come by that point and they've already bought most of them, or, people have traded them off, and then there's a whole lot less. But yeah, I think there is definitely a correlation. I'll pass it on.
Sure. Yeah, and I think sort of at the end of the month too, when government funding would come in, sort of the price would go up a bit too. But I think, from my perspective, I think in my mind I'd be grasping at straws, thinking from a qualitative or subjective point of view, how to put it into perspective. But we don't know what the quantitative diversion rate is, right? We may never know, right? But let's say it was 90%, very high. There are people who have benefited, and I think that's good that their lives have moved on from that point, and anybody's from my addiction, even from my medical training, I never knew what it was like, what people suffer through on the street with homelessness, with addiction, with severe mental health issues. But you take some of those people, and those people who did benefit from the program, I wish them well, and that's a positive thing. How we sort of evaluate that with the harm that's being done to people like you and me, our families, we don't know where that's going, right? So
Or even some homeless people, actually.
yes,
I met people.
and it could be the opposite way. It could make their lives even maybe harder,
Yep.
I think, too.
Yep.
For sure, yeah.
Yeah, actually, I would like to
One on
say
that, yeah.
one thing that I did meet, in particular, one lady in one of these buildings who, as I was buying pills off her, as she was injecting Dilaudid into her toes because she, the rest of her veins were no longer good, she was saying, I wish I stayed on methadone. I wish I wasn't in this building because everybody around me has it. I'm not even prescribed safe supply right now, but because it's so available, I can just go with $5 and I've got another pill. So I just wanted to say that before we moved on, because
Yes, well, so to build on your point, there are, I speak with many doctors, addiction doctors through my work, and what I hear quite often is that enrollment into methadone programs has collapsed. Addiction recovery care, has kind of collapsed because everyone wants to go on safe supply. Because it's easier to just stay addicted to all these free drugs than to do the hard work of recovery. And what that means is you have all these people who remain unstable because of this program, and then they end up on the streets because they've been robbed of the opportunity to get better, and their addiction has been enabled and exacerbated. And then you see encampments that are persistent partially because we're adding fuel to the fire, right? So I think that's one thing that we should be mindful of. Now, I did interview recently at a conference a safe supply provider who was very for it and said that some of the people that she worked with had stabilized, and that she said, yeah, they sell their Dilaudid, but they make money, and that money stabilizes them. And I think the problem here is that these safe supply supporters, they miss the forest for the trees. So they only see the extremely unstable patients that they're working with, and they say, okay, they sell the drugs, they're stable, that's okay. But they never think about, well, those drugs are being sold somewhere and they're being consumed by someone, and they never think about the teenage girls, or, for example, the construction workers who develop addictions due to Dilaudid, and then who will eventually end up in encampment 5 to 10 years from now, if not earlier. Next question. You asked one earlier. Is there anyone else that has anything to ask? No? Okay. Oh wait, way at the back.
Sorry, I was just gonna ask, so the implementation is problematic? That's what's causing the problem?
Yes.
So when you're, and I'm sorry, I look at words wrong, because I'm sort of a novice at this, but the methadone, when it was prescribed and monitored, was actually helping people.
Yes.
But the way that it's done now, because of whatever greed, I don't know, and its widespread nature, is amplifying the amount of drugs that are in the system, and it's kind of out of control.
Yeah, so there are two main problems. One, that this is unwitnessed, and two, it's not recovery oriented. So there could be a model of safer supply that works, where it's strictly monitored, so there's no diversion. And actually, Lori would be the best person to answer. She's put her hand up.
Just to clarify, methadone is a long-acting oral opioid, which you would drink once a day. So you go to the, when you're unstable, meaning like you're still using your other drugs, you go to the pharmacy, you drink it in front of the pharmacist, and once your dose is, and it takes a couple of weeks to get the dose up, then presumably you would stabilize, meaning you don't crave the other opioids, which are short-acting. So these take-home tablets, if you inject them, you might feel okay for a few hours, if that's what you're injecting, or you're injecting fentanyl. Either way, you're only good for a few hours. Your whole life is consumed with getting the next dose. Whereas methadone is, okay, once a day, go to the pharmacy. Once things are going well, and maybe I got my job back, and I got a place to live, you get to take home some of your doses. They're unobserved doses. The witness part, as you're saying, the implementation. So if we were to say to people, okay, you can swallow these 4 tablets of hydromorphone right now, drink your methadone, and away you go, which is what we asked them to do in BC, that might be helpful. Most people aren't that interested in that. So, but the key thing is methadone is not safe supply. It's different. Hydromorphone is a short-acting opioid. It's dilaudid. So.
Yeah, methadone is like, it's an opioid, long-acting opioid that you use in just the right amount to manage withdrawal, but not to induce euphoria. Safe supply is, I mean, it's sort of for withdrawal management, but it's also for euphoria induction. Right, so it's supposed to be an alternative to using street drugs. So the idea is that if we had a strictly monitored, so like strictly witnessed system, and we used it, and we gave people only safe supply for a few weeks to help them transition onto methadone, to make that transition easier, to incentivize people to get onto recovery-oriented care, maybe that would be helpful for some patients. But right now, we give it to them indefinitely, which enables them, and there's no witness consumption, so they stop. Do you guys agree?
Yeah, actually, I'd agree. And like, even if you could get, a recreational effect from methadone, it's so closely controlled that, it wouldn't matter. Because it's not like they're giving you your whole week's doses all at once. You can't just overdose on it. They're giving you only one dose for the day, and then you gotta come in for the next one. And they'll maybe give you carries after a couple of years of good behavior. And with Suboxone, right, it's, less abusable. Like a lot of people I met, in addiction and even in rehab that had opioid problems, they hated Suboxone for the same reason I chose to take it. When they gave me the option of methadone versus Suboxone, I said, I'll take the Suboxone, because everybody I said, I hate methadone. You can't feel anything on it. It's like, well, that's the point, and it lasts longer.
Wait,
And-
you mean Suboxone, you mean Suboxone.
Yeah, yeah.
You just said methadone. That was, did you misspeak there?
Yeah.
Yeah.
Yeah, that's what I meant.
Yeah.
Yeah, so they'd say like, I hate Suboxone, you can't, I don't feel anything from it, and it makes me feel terrible, which, a lot of times, like, I had met other people who it worked for them completely. Like, there was one guy from Timmins who he worked on, I think, pipelines or something, and he was in rehab, with me, and he was a fentanyl user, and he was on the Sublocade shot, and he said, yeah, it works fine for me. And so, each person has a different drug, but, methadone and Suboxone can both cover it easily. So you could either use one or the other, whichever works for the person, but they're both very good tools for the job. So we already had the tools we needed, you know. I'll pass it off to you.
Yeah, I don't wanna bore with the, or get into, because it's not really my expertise, but we're talking about methadone. Methadone, from my knowledge, is an opioid agonist, correct? Like long-acting. Buprenorphine is a opioid antagonist, but it blocks partial agonist.
Partial agonist.
But so is
Yeah.
methadone is agonist.
Well.
But either way, if you're on methadone, you can still crave other opioids and get high off other opioids. I'm personally on Sublocade, which is a once monthly injection. For me, like you were saying, it was described to me as you will feel like normal, like you were never exposed to opioids. So you won't have that craving, you won't have that withdrawal. It blocks the withdrawal, sort of blocks the that craving per se, of the psychological craving. But with the whole caries part, methadone, now I don't know too much about that, but I know for Sublocade, for me, knowing that because I'm on it, if I were to relapse, and I've never done fentanyl before, the only like opioids that I was severely addicted to was Dilaudid, that if I were to take Dilaudid, it wouldn't get me high, or at least that's what I've been told, because of the partial blocking mechanism. So that's a deterrent as well, right? The methadone part of it, I know that people in the Safe Supply program are still getting prescribed methadone as well. So, and I think we talked earlier about Safe Supply, they're doing Safe Supply Ritalin now too in London.
Yep, they're doing stimulants, they're doing everything, they're doing benzos.
Wow.
All these drugs just like candy.
That's
Yeah.
interesting.
Yeah, and you look at Sublocade, which is what Will is on, it's basically a once a month injection that functions as more or less a vaccine against opioid use and opioid cravings. In fact, at a high enough dose. Well, Lori has something to say.
We have one huge issue with Sublocade, and that is that as soon as you get well on it, which invariably people do when they stay on it for a few months, you get a job that doesn't have drug coverage, and then you have to pay for it, and it's expensive. So we're trying to get the federal government to cover it. Just saying, $700 a month is too much for most people.
That's
So
more than the
for
bills.
ODB, luckily it's covered.
Yes, that's a big
That's a
problem.
huge issue.
So our government will pay to hand out like thousands and thousands and thousands of pills that get resold on the streets that kids end up using, but they won't pay for the once a month injection that immunizes people from addiction and gets them better. And there isn't a strong incentive for some clinics and for some pharmacies to support this, because when someone gets better, you can't make money off of them.
Yep.
But I want to thank everyone for joining us. So we're coming to an end of our program. Thank you for coming out tonight, for listening to all of this, for watching that difficult